started. Let's begin today's program entitled The Impact of Violence Against Women on Maternal Health. My name is Sandeep Pathal, and I'm a senior program associate with the Global Health Initiative here at the Woodrow Wilson International Center for Scholars. Today's event is brought to you as part of our Advancing Dialogue on Maternal Health series, which works to address many critical and neglected maternal health topics. And our series is generously funded by the Maternal Health Task Force as well as the United Nations Population Fund. I do want to point out that we will be, if you are interested in tweeting today's event, we will be using the hashtags MHDialogue and hashtag NewSecurityBeat. As many of you know, the Woodrow Wilson Center is a formal memorial to our 28th president, the only president thus far to have achieved a PhD. And in his honor, we aim to bring the worlds of policy, practice, and academia together to gain a better understanding. You have bios in front of you, so I want to direct your attention now to our three speakers. We have Carrie Clark, who's an assistant professor of medicine at the University of Minnesota Medical School. And then we have Anita Raj and Jay Silverman, who are professors of medicine and global public health at the University of California and co-directors of the program on gender inequities and global health. A note about today's meeting, we are webcasting live, so what that means for you in the room, when we do come to the discussion portion of the meeting, I'd ask that you wait for a mic, and my colleagues will be coming around with them. Please use them so that the folks that are tuning in online will be able to hear you. So why don't we get started officially now. We're going to have Jay go first, and then we'll have Carrie and Anita. Thank you so much. And here's you, if you don't mind coming here, here's the
What
clicker.
I'm going to do is this so I don't have to twist my head around every time.
Oh, okay.
That works. Can everybody hear me okay? This is not a big room. Probably. Well, thanks everybody for taking a little bit of your afternoon. Got to eat anyway, right? I really appreciate everyone coming. See a bunch of familiar faces. So I want to thank the Woodrow Wilson Center and the Maternal Health Task Force for sponsoring this and inviting us to help lead this symposium. Today, to sort of start us off, I'm going to be talking about sort of the state of knowledge of where things are at in terms of violence against women and maternal health. When we speak of violence against women, we're typically including all forms of gender-based violence, so all different forms of sexual assault and sexual exploitation and the like. When we're talking about issues of maternal health, we're typically talking about intimate partner violence and violence from male partners, married or not, and that's certainly what we'll be focusing on today. What happens when I do this? Nothing. I touch that one?
Yeah, that one.
Okay. So just as a quick update for people who are not really focused on IPV, intimate partner violence, this is actually data from a multi-country study, 15 different countries from the multi-country study, many thousands of women, and in terms of ever being physically victimized by or sexually victimized by an intimate partner, the range for the vast majority of countries falls within 25 to 75%. That's a big range, but what's important to take home is that this is a very, very prevalent issue. This is not something that just happens to one particular small group who happens to be at higher risk. What I want to then now do is talk about how intimate partner violence affects women's control over conception, how it affects their health during pregnancy, how it affects pregnancy outcomes, and then just a little bit also on how it affects infant and child health, still focused on violence against mom. And then just a very quick number of minutes, assuming I have any, on a couple of promising programs. Okay, so in terms of contraception, what we see are that married women are less likely to adopt contraception over time if they have a partner who's abusive, And abusive men actually also report that they're less likely to use condoms. Uh, all of these numbers that I'm going to be presenting, there's a whole bunch of them. I want to make sure everybody knows these are adjusted, almost universally adjusted within regression analyses for a large number of other potential factors. So these are not just simple correlations or frequencies. Pregnancy coercion, that's where a male partner is overtly coercing a woman to get pregnant when she does not want to get pregnant. That's 83% more likely when there's an abusive male partner in the picture. Unintended pregnancy, there's been many, many studies on this, very consistent, where about 50 to 70, we see a 50 to 70% increased risk for unintended pregnancy based on having an abusive intimate partner. Now, we talk about less, but it's certainly not less important, and it's not surprising when we see these numbers about unintended pregnancy, is that women having abortions is also far more likely, up to about 3 times more likely. There's been about 3 different studies on this so far, probably more that I've missed. And beyond that, repeat and rapid repeat abortion. So really important indicators of a lack of reproductive control, which is certainly a critical piece of what we're talking about today. In terms of pregnancy, getting antenatal care in the first trimester is significantly less likely when there's an intimate partner who's abusive, a male intimate partner who's abusive, typically a husband in all of these cases. These were all studies with married women. During pregnancy, there's a whole host of markers of health risk in pregnancy. A number of them have been studied. No weight gain, preeclampsia, which is high blood pressure, PROM, which is premature rupture of membranes. All of these things occur at higher rates, significantly higher rates, among women who have an abusive partner. In terms of outcomes of pregnancy, in the only study that we have on this, if there's others, I'd love to hear about it, women who were married to an abusive partner were about twice as likely to have a pregnancy end in a miscarriage. And delivering early premature delivery, and about 37% to twice as likely to deliver, and other people in maternal are probably better at this than me, but it's, I think it's before 36. No. Is it 32 weeks? Anyway, to deliver based on standard definition of premature delivery. And of course, people who deal with any of these things, there are obviously huge implications for all of these things. We know a lot about what goes, what are all the risks to children based on being born premature. Maternal mortality, which is obviously, one of our critical statistics around maternal health, is something we know very little about in relation to intimate partner violence. Obviously, ways that we've studied this in these other forms, we're often dealing with reports from women themselves. When we deal with mortality, there's often all sorts of medical records that can, and registries that can be fallen back on. Well, intimate partner violence has not been included in those. There are prospective studies that are going on, but at this point, we don't know. We do have some indicators around, just preliminarily, around hospital-based delivery, things that certainly would make deliveries more safe, less safe. So, very quickly talking about the children, and I know we don't typically include kids when we're talking about maternal health, but what we're looking at here are still associations of violence against mom. So, not surprisingly, based on what we saw before, a child whose mother is being abused by her male partner is 17% to about 4 times more likely to be born at low birth weight. We don't have data on very low birth weight, I think because of these studies haven't been large enough to really have that, have the N to do that. Diarrheal disease and acute respiratory infections, so two major factors in infant and child mortality. So these forms of morbidity are significantly more likely to occur among children whose mom is being abused. And again, all of these numbers are controlled for many other factors that I'm sure we all could think about that might otherwise be responsible for these outcomes. There's been a number of studies around malnutrition and stunting, a little bit less on wasting. And again, we see that not only are children whose mom has an abusive partner more likely to be malnourished in these ways, but in a recent study by Salazar et al. From last year, he found that the effects of that abuse on the likelihood of malnutrition were confined only to girl children. So it's a really important indicator of how much of a gendered impact this is. It's not just, of course, it's a form of gender-based violence against mom, but when you're dealing with settings where women and girls are devalued, then it makes sense that that devaluation, which IPV is certainly going to be a marker for, is going to unfortunately carry over to girl children. This has not been looked at in many studies, but I think it's a very important area for us to be thinking about as we go forward, thinking about maternal and child health. Infant death, there's been a number of studies now that have demonstrated that infants of moms who are being abused are more likely to die, both in a neonatal infant and up to 5. So those are actually 3, I suppose. And similar to what I was just talking about in terms of nutrition, in a study we did a couple of years ago in India, we found that, yes, intimate partner violence is associated with malnutrition is associated with infant death across all children. And then when we stratified the analysis, because we had a big enough N to do this, into effects for boy and for girl children, the effect of abuse against mom for boy children was non-significant. And what you saw was a much stronger effect among the girl children. So similar to that last study, the effects of intimate partner violence, probably a marker for all sorts of other gender-based concerns in these families, and including abuse of children, really has important implications and gendered implications for children. Okay, good. I didn't skip too many things. Okay, I want to just talk very quickly about a couple of what we hope are promising programs, we think are promising programs. One of them we call Chance. This is a program that, to this extent, has been implemented in urban slums of Mumbai, India. Our partners on this study, the National Institutes of Research on Reproductive Health, is part of the ICMR in India, and Population Council, I'm sure lots of folks know. Through a lot of our studies, we saw over and over again that when you're talking about reproductive health decisions and maternal decisions, such as things like antenatal care and nutrition, that women themselves, even though they're the ones we're educating, they're the ones we're often targeting to try to move into care, are not making these decisions. That it is husbands and in some cases in-laws who are making those decisions. And so we realized we needed to obviously be talking to people beyond the wife. And we, at the same time, have done studies that show that the actual violence is really a marker for a much broader set of chronic, mundane forms of maltreatment based on gender. So lack of nutrition, lack of rest, being prevented from getting medical care, all of these kinds of things that are also more likely when there's an abusive partner. So what we did, and we always try to think about things in terms of sustainability and scalability, that's why we work with government partners wherever possible, is to work with the government-funded health promotion, maternal health promotion systems. Right now, across India, they're called different names in different locations, in different settings, but community health workers do a series of home visits across several hundred families, typically, that they're responsible, and they're usually part of that community. They detect when somebody's become pregnant, and they go and they do a series of visits to try to improve maternal nutrition, talk about things like folic acid, talk about safe delivery, antenatal care, et cetera. So what we've done is provide a retraining program for community health workers to allow them to talk to husbands and in-laws as well, and to integrate in a somewhat subtle way the negative health impacts of husband violence and household maltreatment, really dispelling a lot of myths out there that are commonly held. And it doesn't take very long. We're talking about 20 to 30 minutes, 3 additional sessions over what is already normally done. And in the pilot thus far, we, oh, thank you. Yeah, I'm not good at changing these.
I'll take care of it, Tori.
Thank you. We saw some great improvements, and this is not a controlled trial. That's important to know, but here's, preliminarily, what we're looking at is significant improvements in utilization of antenatal care, improvements in marital communications with husbands, specifically around issues during her pregnancy, needs around pregnancy, reduced fear of husbands, reduced forms of household maltreatment, including access to nutrition, and actually reduced reports of violence from husbands against pregnant women. So this was all among women who had given birth in the last 6 months. Actually, no, we did the pilot. That was the other study. We got people who were within 3 months of becoming pregnant and followed them up into the 3rd trimester. The next step is obviously hopefully a randomized trial. That's what you want to try to be able to do in NICHD, and the Indian government were good enough to approve an application of ours to do a randomized control trial. However, there's a treaty between NIH and the Indian government that's hasn't been signed, and it's been waiting 2 years. And so, unfortunately, I'd like to be able to say much more than I can about this, but we're looking for other partners at this point to keep things moving forward. Reproductive coercion. What we've seen with women attending family planning who are having these issues we talked about before, repeat abortions, unintended, unwanted, unplanned pregnancies, mistimed pregnancies, that, again, we see the intimate partner violence is really a marker for these other forms of often non-violent coercion. And those, we've done studies where we've identified those forms of coercion, and with Futures Without Violence, and with Dr. Elizabeth Miller, who's at the University of Pittsburgh, we developed an intervention to try to reduce reproductive coercion and then improve other health outcomes in terms of fewer unintended pregnancies, et cetera. It's a very brief intervention, again, working with the systems that are already there, working with standard of care to provide a brief training, 1.5 day training to existing family planning counselors to be able to work with their clients to help them recognize connections between violence against women and their reproductive control, to do harm reduction based on what are the issues that are happening in terms of if there is coercion, if there's disallowment of use of birth control, for instance, using forms of birth control that are not easily detected by a male partner. And lastly, connecting to available relevant services. Sometimes those are specifically about intimate partner violence. Sometimes there are others because the longer-term service obviously can't be provided at the family planning clinic. In an RCT involving, our first RCT involving a little over 900 women at 4 different family planning clinics, and this was controlled, we did see a large reduction in the risk of pregnancy coercion, and surprisingly, a large and significant reduction, increase rather, in women relative to in the control group reporting that they left an abusive relationship, that they left a relationship based on their concerns for their safety and health based on a partner's abuse. We did not expect that. What we've been able to figure out in the qualitative data is basically that for women who have the choice of leaving, so people who are not married, typically we're leaving, it's not a big deal, people who don't have children, that over a year's time they were making different decisions about their relationships. Not everybody has that option, but that's what we're seeing. And we have a very large randomized trial, control trial being conducted now with about 5,000 women over 20 clinics. We're be excited to disseminate the results of that. So just ending, violence against women is obviously a major factor in maternal and reproductive health. And beyond all this epidemiology that demonstrates this, and hopefully it's clear enough that people are not in doubt about whether these effects occur, there are interventions that can absolutely reduce violence against women and improve the maternal and child outcomes that we've talked about. There's things out there often that have not been rigorously evaluated. That's certainly something that everybody knows we need to do more of. So we need to identify those programs, rigorously assess them, and adapt and scale them for different places. The reproductive coercion intervention that I just mentioned, we're in the beginning stages of modifying it for implementation in the Caribbean. But I'm going to stop there. Thank you all so much.
Thank you all for being here today. I'm going to be speaking about our research in the Middle East. And I'm going to start off by saying that over the last 10 to 15 years, we've really seen a growth in research on violence against women and women's health in the Middle East. And these numbers here are some of the more recent findings, often from demographic and health surveys, which many of you are probably very, very familiar with, or other national surveys. And the fact that there are large surveys of this nature is a feat in and of itself, because we've been able to start to document the extent of violence against women in the Middle East. And this here I'll be speaking about is intimate partner violence. As you can see from the table, there's sort of a wide range of prevalence estimates, but the sort of underlying common feature of all the findings is that it's an extensive problem in the Middle East as it is in the rest of the world. Another common feature of studies that we've done in the Middle East is that there's still quite widespread acceptance of wife abuse under certain circumstances. Oftentimes, when the wife is perceived to have committed some transgression. The other side of this coin is that we're also seeing change over time, and especially the Egyptian DHS study is a case in point where you can really start to see time and time over that we're starting to see real reductions in the percentage of the population who endorses these items as it being acceptable. So while there's still quite a lot of work to do, I think everything that I have to say today has the silver lining and the positive side, and that change is happening. For all of you who work on violence against women, this figure is something you're very, very familiar with, which is the ecological model. And it really starts to highlight the various contexts in which that influence the occurrence of violence against women. And this is the one from the World Health Report on violence and health. And one of the areas that I think Jay really mentioned in his research really highlighted the role of the extended family and starting to think beyond the relationship and really what's going on in terms of women's risk of violence and their health. And in the research that I'll be talking about, that was also a key factor that arose, is really thinking globally about violence against women. It's thinking about the woman, her partner, her children, but really much broader into her wider family, his family, the community, their neighborhood, all the influences that are impacting the occurrence of violence. So I'll be talking to you about a comprehensive study that we did in Jordan and sort of trying to draw connections to other findings in the region where possible. Dr. Silverman is a key collaborator on this study, and while Dr. Raj was not, I've been channeling her work for many years, so I've been heavily influenced by her work both in Asia and in immigrants in the US. So the objectives of the study were really to start from the very beginning. When we first started this study, there really weren't large studies on this issue in Jordan, and so we started pretty cautiously, in part because we wanted to be ultra ethical about how we approached it and to make sure that no one was harmed. But we really wanted to get a good estimate of intimate partner violence that examined the issue the north, middle, and south of the country. We also wanted to look at risk and protective factors and look at the reproductive health correlates of women's experiences with violence. We did this in a mixed methods approach, which I really, really highly recommend, and you'll see that the multi-country study and many other studies, large studies, do have a qualitative component, which I think is key to really understanding the statistics. We started out with a qualitative component, which was to conduct 17 focus group discussions with a number of partners around Amman and Greater Amman to really get a sense for how women defined violence, because we wanted to follow up with this survey, what the risk and protective factors were, and frankly, if women would participate, if we would be able to ask them safely about their experiences of violence and where we might do that. So it was both in part feasibility, but also incredibly rich content that we've been able to use throughout the survey and also as standalone data. In terms of the prevalence of intimate partner violence, we were using the World Health Organization's multi-country study items that were being fielded in other countries at the same time. We added, based on the focus group discussions, a few items here and there to the control and the psychological violence pieces, which is really where we found sort of gaps in the WHO measure. And the WHO documentation is very clear that it's really hard to sort of systematically and measure psychological violence in a very standardized way. But we did find a very high reporting of controlling behaviors, which was not unexpected. Psychological violence, about nearly 3/4. Again, psychological violence is typically one of the most frequently endorsed forms of violence. 31% said that they had been physically abused by their partner, and almost 20% reported that they had experienced sexual violence from their, when I say partner, I mean their husband or ex-husband. In terms of putting these rates into a context with the WHO study, which is sort of its closest companion, these rates are, you saw Jay presented some of them, they're wide ranges, and these fall, of course, within them. The only one that is a little bit high is the sexual violence, which is towards the upper end of the spectrum in terms of the WHO range. We were also looking at, in terms of our risk factors, really trying to, based on our focus group discussions, we were able to incorporate a number of those into the survey design, and really the extended family just really showed up. If we didn't think we were going to measure it in the first place, we definitely measured it after the focus group discussions, and we found that the extended family is really key. It's key in part because it can be extended meaning both the natal and the married families. It's key to her risk in terms of living in situations where you're living with your mother-in-law. In Jordan, anyways, increase the risk of women's exposure to violence. It was also one of the strongest protective factors for women who could call on their families, who had good communication with their families. It was very clear quantitatively that there was a reduced risk of violence. Also qualitatively, the family, it was really remarkable about how they were able to call on their families. Instances, personal stories, neighbor stories, the whole gamut, and also the stories of families who weren't able to help or were unwilling to help. And we'll speak a little bit more about that in just a minute. In terms of some of the reproductive or maternal health effects that we found, larger number of children was associated with women's experience of violence, unintended pregnancy. And one of the mechanisms we think for these findings is really interference in women's attempt to limit their fertility. So the clients, the study participants were clients at the local IPPF affiliate, the Jordanian Association for Family Planning and Protection. And still, even though women were going to a family planning agency, 20% of them reported that they still had interference in their use of contraception, which is pretty remarkable since they already had permission to go and they were freely going, but they were still facing some issues at home, which then you can imagine for the women who weren't able to be going to such clinics that this was probably a huge underestimate. But we found that those who experienced violence were much more likely to also be struggling to limit their fertility. And we also found that 15% of these women reported physical violence during a pregnancy. This table that I'm presenting here are some of the figures from some of these large surveys on women's experience with physical violence during pregnancy. And you can see that across the spectrum, even a 6% is not small, given the health consequences to the woman and her child. But you can also see, for example, the study among Bedouin in north of Jordan. When you start to add in isolation, low socioeconomic status, many other barriers, you see that the risk of violence, as you would expect, also goes up. So there's a huge unmet need in terms of services for women. One of the activities that we were doing, and I alluded to it a little bit when we were talking more about the broader risk factors, is also looking at the factors that influence IPV during pregnancy. We found that husband alcohol use, which is not actually frequently measured in a lot of the research in the Middle East, which I think is an omission, because while it's not a very frequent occurrence, it's more of an aberration, and these individuals, women who have men who do drink or drink to the excess, are at greater risk of violence. Other risk factors that are more typical in the IPV literature are frequency of arguing. The belief that the wife should be obedient was associated with increased risk. And again, you see that family support, a woman's education, which none of you need to be told the importance of a woman's education for any number of health and development outcomes, but certainly it's a protective factor for violence against women. And in this particular culture, marriage to your cousin, a close cousin, was associated with a reduced risk of violence. Finally, I will talk about women's responses to victimization, and this will be both from the qualitative research and from the survey research. And that, hands down, the main finding is that the family is the best, and for most women, the only source of assistance that they could imagine trying to access. Going outside the family was perceived and experienced by a number of women to have really serious social, financial consequences. I'll tell you that the most emotionally moving groups were divorced women who were trying to make it on their own with this intense stigma and social pressure of trying to make it and raise her children outside of her family and that of her husband's. There were also women who were extremely grateful for having made the same choice. So the support systems around these two different women are very different, but there are different trajectories that women can take. But there's no question about that divorce is still a very stigmatized status to have, and it made it difficult for women to get help. As you would expect, most of the victims in our survey did not seek help. 60% did not. Actually, the fact that 40% did is actually high. Very few women use the criminal justice system or social services or government organizations or religious leaders, although, again, on the other side, several women did. Part of our recruiting strategy was to include women who were seeking help at a women's NGO. Some women were fearful. They had just started the process, but they were hopeful. They were hopeful that these organizations could help them. There were other women who had been helped, who had already moved through the process and were now living a life free of violence. And while they were strained financially and socially, they knew that they were exactly where they needed to be for themselves and for their children. In both the survey and in the qualitative portion, no one was using the health system as, or perceived it to be as a source where they might get help for violence. Those who did seek help outside of the family were those who didn't have family to help them in the first place. Anyone in the survey who had gone to anywhere outside the family had also accessed their family first, or their family couldn't help them. In terms of the qualitative portion, some families were just too poor, because on average a woman has between 3 and 4 children, some more in our sample. And for some of these poor families in crowded settings, they felt that they were unable to bring the woman and her children into their home for safety. Other families were unable to or unwilling to help the woman's children, but they would gratefully take their daughter back in. But considering that the children are her husband's lineage, some of the women were finding difficulties with their families to leave their abusive situations and stay in families of that nature. So those women are much more likely to seek help outside of the family. And of course, women whose natal family was abusive to them is unavailable to them, of course, as victims of violence. And those who sought help outside of the family also suffered much more extreme abuse. So on one hand, there's still not a lot of use of formal services for victims of violence. On the other hand, they serve an extremely vulnerable population, and their maintenance and their improvement is, of key importance. So the implications for this study for programs and policy is really, continued efforts. There have been efforts going on to try to change attitudes, raise awareness of the health effects of violence, especially in Jordan, but throughout the Middle East. And continued support, especially when you see very high percentages of women and men who still think that violence against women is acceptable, means that we need more efforts in those areas. Also, continued awareness raising around violence against women, their rights and their help options, because many women in our study were not aware of the options that were available to them. So some of it is just pure awareness, but other is really dealing with the stigma of going to the police or the negative outcomes that might come for really going outside of the family. As Jay mentioned, really the extended family and men are key partners, and they must be key partners in violence prevention. It's the place where women want to get help. It's their most effective form of help when it works for them and when families are able to do it. So to support families who are ready and willing to stand up for their daughters but don't have the space, they don't have the funds, they don't have the legal knowledge to help her navigate the legal system, that would be a win-win for the family and for the woman. And finally, there are innovative programs going on in Jordan. USAID has a very nice extensive program, so does UNFPA, really trying to work multi-sectorally, improving the health sector response, really assisting these NGOs in their efforts, working to improve the policy environment. And as a researcher, I have a special place in my heart for Jordan, and I'm going to, for sure, follow up and continue to monitor how these programs are impacting, and I will really watch out for any evaluations of these efforts, because they really have the potential to transform attitudes and women's experiences and their children. And I can't say enough about how important they are to continue them into a next cycle. I'll stop there. Thank you.
Would you be okay if I put this here?
Yeah, it should reach.
I'm a little shorter than the other presenters. So we'll just see if I can. It what's gonna work? And that'll go in front of me. Okay. We'll do it down here. Okay.
I can move the podium if that's easier.
Yep, I can do it. Okay. Hi, thank you so much for inviting me to the Wilson Center, and to all of you who came. It's an amazing turnout. It's a hard act to follow. They have covered so much material. And what I'm going to do is I'm going to talk a little bit about the work we've been doing in India to take a lot of what has been presented and think about how we can integrate it into programming that for development and for evaluation. We are a group of researchers from the US, but also from India through Population Council, who are collaborating with the researchers from the Indian government to come together to really focus on these kinds of gender inequities and gender-based violence and the impact they have on sexual and reproductive health. Particularly, I'm going to be focusing on our interventions that have as a goal improved HIV risk reduction practices and improved family planning behaviors. This is part of work that is within our program of gender inequities and global health that Dr. Silverman and I have recently started at UCSD, and it is very much our perspective that improving gender inequities and improving the equity of women, the treatment of women and girls, the value of women and girls in society is a very important means of improving population health. So I will move forward. I'm going to start with a project that focuses on HIV among women. This was a project funded through the National Institutes of Health and the Indian Council on Medical Research. I want to acknowledge my program officer very kindly from NIH, took the time to come in and hear the presentation. So a little bit about HIV in India. About 2.3 million individuals are infected with HIV in the country. 39% of these are women. The primary risks, when you look at the national data set, are related to marital status and age. Marriage is actually a significant predictor of HIV risk. Sure. Sorry about that. I didn't even notice it on the screen. These are significant predictors of HIV in the country, but also being urban and middle income. When you look more carefully at among infected, married women who are infected, what are the two key factors at play? Factors that relate to their husbands, that he is more likely to be a risky drinker, and that he is more likely to engage in spousal violence. And this was actually research that was published by our collaborators from Population Council in terms of the alcohol, Dr. Sagurthy and Dr. Silverman, as well as Dr. Decker, who was a fellow student of Dr. Clark. Small world. But there's very few interventions. A lot of what you see in India has been a focus on men, husbands, migrants, and a focus on female sex workers, because these two indicators appear to be a marker of male involvement with commercial sex work. So what we came and presented as a proposal was something that was very, very innovative at the time, and really a lot of people didn't feel like was a good idea, that we would work with the wives. You can't work with the wives, it's the husbands who affect behavior. But we felt that it was very important to have a perspective that women should have the capacity and support to affect their lives and health. And with that in mind, we focused on the Rani Wives study. The Rani Wives study was specifically for women in a slum community or in slum communities of Mumbai where there were high HIV rates and known large red light districts. We specifically were working to identify women who report partner violence or spousal violence. I'll use IPV because frankly it takes less space on the slides. And husband's risky alcohol use. We did household recruitment. It was a lot of households. This was probably the biggest problem we had with the study. This was not the optimal way to recruit. Because disclosure through that means was far more difficult than we had realized. Nonetheless, we were able to recruit our sample size of approximately 200 women. And we had half the women were in areas where we provided the intervention and half were not. So a little bit about the intervention. The intervention focused, it did individual counseling and there were some group activities, and we focused on marital stresses. This really came from the formative research because that's what women were interested in. And what were the stresses in their lives? The financial stress, the alcohol, and the abuse. And this was all very much interrelated for these women. And so coming at it from that perspective was the salient way that they would be able to sort of digest the information in a way that was meaningful to them, but also comfortably, because these were very stigmatized issues. We also focused a lot on marital communication. We initially had come in with the idea of like, well, he's abusive. It's not that she can't communicate, he's abusive. And we were told flat out, that is, listen to the women. And we did formative research, we heard what women had to say, and a lot felt that they could affect their marital relationship by being able to talk about these issues, by being able to gain supports in their lives, and by being able to implement those strategies on their own. And we really wanted to be proponents of having an intervention that they developed themselves, and that was sort of the nature of the program. And so it, of course, included identification and skills building around use of social, informal and formal supports. It was a 6-week program, so relatively short. It had 4 intervention sessions that were conducted in the household. It had 2 group sessions, and I should tell you, the group sessions were not big successes. Women were very busy. Some of them did not feel so comfortable participating in the group sessions. So when I present the findings, and I'm going to very briefly present the findings, I just want you to bear in mind that we really think that this is the product of the 4 individual session model. Now, one thing that we had to think about was these were really sensitive topics. Whether we were doing the survey or whether we were doing the intervention, we were going to be asking women about things that were very personal. And we wanted to make sure that the communities that we were working within were ready to know about what we were doing, understand it, and receive it. So whether they were in the intervention clusters or the control clusters, everybody received street theater. Street theater is a very traditional, it's many traditions have it. We had a group of street performers who came together. We told them a little bit about what the focal points of the intervention were about. They created an intervention, a play, and then we gave them feedback based on the formative research and empirical studies to say these seem to be the primary risks. One of the things at hand is people did not want to hear about HIV/STI, which was the focus of the intervention. Shocking, I know. What they were really more interested in was hearing about the alcohol messaging and the spousal violence, because those were the issues that they felt were more relevant in the community. And there was a community consciousness that didn't just include the women in the community, but the men and the political leaders as well. So street theater was done. If you can see the picture, this is the wife. This is someone in the community that comes and says something as he is accosting his wife. I'm sorry, I know I'm on webinar, I apologize for that. So I'll just say it again. You have the wife in the scarf, and then someone who's come from the community to intervene, to talk to him about it. And this, sometimes it could be a male intervention, or a male community member to speak, and sometimes could be a female, but it was the notion that somebody could come into the household and affect this, that this was acceptable, that this is a socially acceptable approach to take within your communities to support protection of women. One of the things you can also see from this slide is mostly male attendees. We're out on the streets. Lots of men, lots of children. And that was very strategic, we felt, to try to move people to think about these issues. Then, in terms of the individual sessions, what we did, and this is sort of a fuzzy picture of the woman because we have permission to present it, but we never want to, it's very, we want to protect the sensitivity of the participants of our programs. That we had them identify the issues in their lives, really focusing on those factors of financial stress, alcohol, partner violence. We didn't bring up HIV, STI initially. We sort of talked about this, talked about the nature of the marital relationship, moved into discussion around the sexual relationship, and then came in to the risk for STI, HIV. And what we did, the way we did that was we'd first have them label the problems. Every session was like this. Have a thermometer. How severe are these kind of problems in your life? Then cyclical drawings. How do they connect to one another? Because remember, this is a largely non-literate population. It was actually, even those that attended school, many of them didn't have basic literacy skills. And then storytelling to sort of normalize and destigmatize the nature of the issues for them so that they didn't feel so isolated. And the stories also included a focus on the problem-solving action plans where the women had solutions in the stories. Then the interventionist would work with the woman where she would identify action plans for herself that would build on the following two features: communication with partner and formal and informal support. And we just did it over and over, and it built from session 1 to session 2 to session 3 to session 4. So what are the findings? I'm not, for those of you that are not really statsy focused, I'm going to tell you what they are, but this, for those of you that are, here is my beautiful p-values for you all to enjoy. We're very, very proud of this. We actually, the intervention was not very long. We had an R21, so that's only 2 years of funding. We graciously got a no-cost extension for 3. Thank you, Dr. Peckmanot and NIH. And what we were able to do is to see with a 3-month follow-up, which is again very short, that we saw the unprotected sex reduced for the intervention participants to a far greater degree than the control participants. So we got an impact on unprotected sex. We then wanted to see, was this about a reduction in sexual activity? Because we've seen that in many studies before. Or was that about an increase in condom use? We, in fact, found no effect on sexual activity. It was, in fact, an increase in condom use. This is the finding I really wanted to share with you. These are the findings, though. We additionally looked at spousal violence. What we found was both groups had reported statistically significant reduction in partner violence exposure. However, in terms of the sexual coercion, our intervention group had significant reduction from sexual coercion from husbands, where our control group did not. So just really briefly, it had an impact on HIV risk reduction, and it had an impact on reduction of sexual coercion in the marital relationship. To our knowledge, this is the only study where it focused in South Asia on issues of HIV risk within the marital relationship and has this kind of findings. So we're very, very proud of it. Okay, I'm going to move on from HIV, and this is sort of a study we have now. This is funded by, well, actually, I'm going to give you a little background and then do the study. I'm not going to go in great detail because so much of this has been covered so efficiently by the previous speakers, but just generally, in the context of India, rural India is disproportionately affected by the high and early fertility that's linked to early marriage and low use of spacing contraception. These have been very much identified as reasons for maternal and child mortality rates having inadequate declines in India. One of the things that we started looking at more carefully was, everybody's been presenting on partner violence, but related to partner violence are other gender inequities. And contraception use is very much affected by these. Number one, adolescent wives, those experiencing marriage as an adolescent are more vulnerable to violence. But in addition to that, those who marry as minors, even into adulthood later years, continue to be more vulnerable to not engaging in contraception use. Daughters-in-law, that's the bill part, daughters-in-law in the household are more vulnerable than wives, which is coming back to what we were hearing in Jordan. It's a very important issue in South Asia. And having no sons, which is really about this concern related to son preference. If you don't have sons, then the issue of contraception is very much affected because of the desire to have sons. And I'm going to present some data, probably too much because I just got the data about a week, 10 days ago, and so all of it looks important to me. So I'll try to highlight key features, but a lot of it's in here. One of the things I want to share with you that is just from a report we published with World We Want, a UNICEF report, what we found was that early marriage and indicators of non-contraception use in the form of short interpregnancy intervals, in other words, having the births less than 2 years apart, these are associated with maternal and infant mortality. But I'm going to give you a rock-hard number on this. Even after you adjust for all the social inequities that we want to consider affecting infant mortality, 150,000 infant deaths in 2012 were attributable to the combination of young motherhood and low birth spacing. So the need to work on these issues and work on them immediately cannot be overstated. Right now we're working on a project called CHARM, and it's a gender equity program with husbands. It focuses on family planning. It's using public-private partnerships between local village providers who are male and the public health system in India, often in the form of what people call primary health centers or sub-centers in the country. And what we're doing is there's outreach from the medical provider to the men to engage them in the process of understanding the relevance of their role in family planning, to bring them in, to have that conversation, to educate them, but as part of that conversation to really bring up these issues of gender inequities that impede contraception use. And that includes things like in-law involvement in decision-making, son preference, partner violence, and the marital communication and joint decision-making. Family planning methods are provided by the village health provider, the local provider at no cost, through the public health system, making the public-private partnership. We only require one session for the men. They may have 2 sessions, and a couple session is optional as well. And these are some pictures actually from the field. This is an example of what, in English, it's obviously not presented in English. It's actually presented in pictures. Only pictures when we show it to the individuals. This information is on the back in Marathi for the village health providers to explain key pieces of messaging we want to impart to the participants. So I'm going to tell you a little bit. This data is hot off the presses. We just got it. Thank you, Pop Council India, for getting these to me so quickly. We've had 50 surveys, 50 villages have been surveyed. We have about 1,000 couples. They are participating in the 2-arm study. Our participants are 18 to 30-year-old husbands and their wives. Anyone reporting sterilization was excluded since it was a family planning-focused intervention. We expected to have 10% of the women that we recruited, because we were doing very broad recruitment, to be pregnant at the time of interview. 21% were pregnant, 1 in 5. You can see that age at marriage for the wives was from 2 to 30 years. Age at marriage for the husbands was 11 to 30 years. 86% of this young sample had given birth. 21%, as I said, was currently pregnant. Only 6% had reported contraception use prior to birth. 62% have never used contraception, and consistent with findings from the DHS data from India, 33% have had a history of spousal violence in their relationship. Most relevant for the discussion today, I want to highlight the justifications for partner violence endorsed by men. 34% said, yes, a woman should be abused if she goes out without telling her husband. 47% said, yes, she should be abused if she's neglecting her children. 35% if she disrespects her in-laws. These are all incredible vulnerabilities that we have to be addressing, and we have to do it immediately. Okay, I'm going on to the next program, and I know I'm going quickly, but I'm trying to sort of present as the body of work and the different ways we're engaging with different groups in the community. We have another grant that was a supplement on the NICHD, ICMR NICHD grant that we got that really focused on the issue of early marriage. And what we wanted to do was do a field survey with unmarried youth as well as their parents to understand their sort of attitudes around early marriage. And the goal of that was to be an early marriage intervention. When we collected the data, we collected information on gender equity issues and contraception use ideologies. And I'm going to share with you some of the findings because we are out now expanding the nature of the designed program to include the issues of gender inequities and contraception because of the findings we've gotten. Can you all see this? So you can see there's the fathers, the mothers, the boys were 16 to 21, and the girls were 14 to 16. We did slightly older boys because these are the typical marital partners of the girls, and we wanted to get a feel from both groups. What you can see is that if endorsement of child marriage was very low, people did not feel, people felt marriage at 21, marriage at 18 was the youngest. People were very clear. They were very aware around the issues of early marriage of girls. When we asked these questions, though, we got some very interesting answers. Should girls be able to decide who to marry? 49% of fathers said no. 19% of girls said no. When they should marry, 43% of fathers said no. These are the most, I focus on the fathers, but you can see the fathers, the mothers, the boys, and the girls. But 1 in 10 girls even feel for themselves they should not be in the position to decide when they should marry. We asked the question, should contraception use be used in marriage? 44% of husbands said no, it should not be used in marriage. 58% of wives, charm is my husband's wives, I should say fathers and mothers. 42% of boys said it should not be used in marriage. But this is most important. 86% of girls said contraception use should not be used in marriage. These are the ideologies permeating in the community, and we need to be much more aware of them because we need to be focusing on earlier targeting for interventions to promote family planning. Do you remember what I said? Early in marriage, only 6%. This is within the same region. Only 6% of people used contraception prior to the first birth. Well, when you look at these, you can see that that's not really changing for the next generation. I'm also going to can you all see the data? Yes? Okay, I'm not going to go in detail on this, but you can see again some of the endorsement of justifiable reasons for a husband to beat his wife. I'm going to highlight disrespect for in-laws for a moment just as an example. 26% of fathers felt it was justifiable if disrespect for in-laws occurred, 20% of mothers, 19% of boys, and 14% of girls. Now, if you are going into your marriage or supporting your child to go into marriage with these ideologies, of course, there is going to be continued abuse that can occur and great vulnerability for girls not feeling that they could get the support at home that you talk about. And we, too, have had this issue of girls unable to go home because of the children and sometimes because of the risk it poses for their younger sisters. Because people will not now have their sisters married, and marriage is so important within the context of these cultures. So what we're doing now is we're disseminating the findings. We're doing some curriculum development. This is actually a program in the field where we're talking to the youth leaders and giving them some basic trainings. We have moved the focus beyond early marriage to really highlight issues of girl choice, to highlight the issues of spousal violence and the acceptability, and to consider family planning education as well. The plan is in this program that the boys and girls trained with support from parents who will serve as the adult advocates surrounding the youth advocates will impart the messaging to other youth in the community around these issues through informal conversations. So stay tuned for those. So, what are the conclusions and implications of these findings? Well, I think that or I hope that what I've been able to share with you that in the context of India, but I don't think unique to India, across our areas of focus on issues of sexual and reproductive health, gender-based violence, but also related gender inequities, things like son preference, expectations of girls' rights to decision-making regarding their reproductive health and their marriage, abuse from in-laws. They work together to heighten the health and vulnerabilities of women and girls, but in particular for this forum, maternal health. On the ground, community and clinical interventions are showing amazing promise, and we've seen this, through the previous discussions. And I think that the importance of this is it's showing promise to diverse populations with women, with men, with youth. But there's some issues to consider as we think about these data. Number one, Right now, there's a real emphasis on the focus on development and upstream approaches like girl education. Girl education is incredibly important, and without it, we will not move forward. But by itself, I do not believe we will move forward. We have to be continuing the on-the-ground work, because the most vulnerable populations, if you educate the girls and there's no change in how they're valued, treated, supported in their communities, it's not going to alter their situation sufficiently to have the kind of elimination of gender-based violence we have as our goal. Innovative programmatic models like these are being developed, and I guess we're all on the same page, but they're being upscaled often without rigorous evaluation. We really need to rethink this. I am on the phone with foundations now where they are really talking to me about how they're struggling. They've got these wonderful program models. They don't have good evaluations. I can say that, from our experience, involvement of NIH has been huge, huge. It has made a difference in having randomized control trials. And if that's what we want to be able to see, then we have to prioritize it. So I want to really push for that. But at the end of the day, we really want to see evidence-based interventions and rigorous evaluations of these. And they need to be large enough and for sufficient time and with enough rigor for us to be able to not just know impact, but be able to upscale appropriately. Things also get upscaled because there's inadequate documentation of the original program model, and then they're not upscaled in a way that was consistent with the program model. So with that in mind, not just evaluation, but implementation science needs to be prioritized more. So I want to close with the acknowledgments of everybody that supported this work. It's a gigantic team. It's the study participants. It's those at UCSD, at Population Council, at NIRH. I particularly want to acknowledge Dr. Niranjan Sagurthy and Dr. Danta Balea for their leadership on these efforts. And then my funders, our funders, I should say, our group's funders, Indian Council on Medical Research, DBT in India, NIMH, NICHD, and Packard Foundation. Thank you so much for your time.
Thank you so much. So we're going to have 2 mics, and we can open up the floor to questions now. And like we said, we are being live webcast, so please use a mic. And for the audience that's joining us from home, as well as those in the room, please introduce yourself and your affiliation. So it looks like we have our first question right back there.
I'm Dr. Hannah Claus. I'm a gynecologist, and I have worked not in India but in Pakistan. I'm very interested in your community-based interventions, both Dr. Silverman and Dr. Raj. It seemed to me that there is such a strong idea of what will people think of me. And I think you need to approach that because, for instance, if you have somebody coming into the house for just 4 quick sessions, just the fact that somebody else knows that you're behaving badly, it can be a constraint rather than an internal change in attitude. And I'm wondering, can you get at that at all?
I can speak to that, which is, where were you when we were recruiting for Ronnie Wives? It was a big mistake. We should not have done household recruitment for that reason, because you're absolutely right. I think that one of the reasons we saw some of the effects we did was these were women who were at a place where they were ready to get help, even if it cost them the recognition, and that is a bias of that research that we really need to be considering. I don't think that undermines what we found, but I think it does have meaning for how it could be replicated. And with regard to charm, one of the nice things with charm and Y Care is that the notion of family planning and early marriage and all, it's not the stigma of partner violence and of HIV, and I think that has greatly facilitated what we're doing. And actually, Chance, I think, is even better about doing that.
In both of the interventions that I talked about, we're utilizing the folks who are already providing services. So particularly if we're talking about the Chance program, this isn't some person who normally doesn't come by. First of all, this is what happens whenever anybody gets pregnant, and it's somebody within the community. So there isn't any additional stigma, I think, that we have risk of in that case.
Do we have a second question? I think we have two on the side here.
Susie Johnson, United Methodist Women. Can you speak to the idea of, I direct public policy for our organization, the policy implications of your research and the sort of loop back to have impact through policy on building awareness as well as transforming behavior of men?
Well, we obviously it's wonderful to be in forums like this. We partner with a good number of organizations to get both form the studies that we do and get those results out. The work that Dr. Raj was talking about with CHARM, with men, she also has a number of other studies with men domestically. We agree is very, very important, and there's a high interest in figuring out ways to work with men like this. In terms of policy, beyond this type of program implementation, that's a harder nut. I mean, we've done some congressional briefings. Basically getting this work sometimes in like popular press is something that where policymakers sometimes then are able to take notice. Do you have anything to add?
Well, and one of the things we've tried to make a very conscious effort of doing is actually collaborating with the governments from the start. So, for example, ICMR is who funds us, but we have a relationship with NIFHW, National Institute of Family Health and I may have gotten it right, National Institute of Health and Family Welfare, NIHFW, yes. And so that is the Indian body that focuses on the policies related to family planning program, et cetera. We have a grant under review by NIH that is specifically designed to do epidemiologic research to inform the existing policies. But I think I can speak for us. I don't know if Carrie will feel the same way. I know my limitations as a researcher. I'm not a policy expert. So what we really strive to do is have the relationships with the government organizations and the policy advocacy groups to ensure that when we get our findings, we disseminate them quickly in a digestible fashion. I don't have that 150,000 children or infants died in 2012 in my published paper. We did that, we got the data, and we did population attributable fractions and did all these population estimates specifically to get it in the hands of the policy people. But I wouldn't have even known to do that if I hadn't been working with the policy people, to be told. So I don't know if you have more to add to that.
Well, I will just speak to, in terms of policies and priorities of the organizations, particularly development organizations. The issue of violence against women sometimes comes and goes in terms of funding cycles and awareness campaigns and the continual efforts that are needed to really change behaviors and change attitudes. It's a long-term process. So I would just encourage those who are thinking about priorities is to think about really a long-term commitment to some of these issues. And I think in a number of our settings we've been lucky to find that, for example, USAID and other donors have managed in various ways, and UNFPA and UNICEF, to try to keep this up on the table, in addition to working with, government partners. But in settings where the government is not doing this, it really is fueled in large part by donor funds. So when it comes and goes, the messages come and go. So put that shot out.
My name is Françoise Risa-Kayuzia, and I'm the Executive Director, Action for Reproductive Health, based in Uganda. And we do male involvement in reproductive health, using them as change agents for reproductive health. My question goes to Dr. Silverman. You talked about something that's so interesting, something that I never thought about. We do have a lot of violence against women, and on the factors to do with infants, You mentioned something to do with diarrhea and acute respiratory tract infection. I just wanted to know, I know we do have a lot of that, but I never connected the two, and I would like to know how it works. How
In terms of how
connection.
child health is affected by violence against the mother?
how the diarrhea and acute respiratory tract.
Those particular
Oh.
Mm.
Well, there's women who are, we know this from many other studies, who are abused are much more likely to be depressed and anxious, and that affects people's ability to take care of their children. We also know that the women, when a woman's being abused, a child is also being abused in many cases, and even without the child being directly abused, child stress absolutely relates to child development, especially actually in the early years. Also, we think about autonomy, so a woman's ability, a mother's ability to be able to get care for her child. She probably has less control over those things. And there's a number of other mechanisms that are slipping my mind at the moment. But one thing I didn't mention is that any time anybody's ever looked, there's also just a large overlap between violence against a female partner and violence against the children of that woman.
Thank you. My name is Jeff Muir. I'm with the Public Health Institute. Dr. Silverman, first, a very quick question for you. You used a term, coercive pregnancy, in your
Pregnancy coercion. Yeah.
pregnancy. I'm not familiar with that. Would you be willing to expand on that a little bit? And of course, the other question that comes up for both Dr. Silverman and Dr. Raj has to do with gender-based violence that is not intimate partner violence in India. It's been in the news a lot lately, of course, with the horrible gang rapes that have taken place and the publicity and what the Indian government is doing. And could either of you speak to the relationship between your research on intimate partner violence and other gender-based violence in India? Thank you.
I'll let you take
Do you wanna
this
do
second.
reproductive
I'll do that
coercion?
quickly. This is a large body of work that's been done by myself and Dr. Elizabeth Miller, who's at the University of Pittsburgh, in terms of this construct of reproductive coercion and pregnancy coercion as a specific form of that. These are nonviolent ways that constrain and coerce a woman's ability to contracept, to stop getting pregnant. It includes a number of different mechanisms, including birth control, sabotage, condom refusal, threats about what the repercussions will be for her if she does not get pregnant, violent, and otherwise. That can also be in the family context. We're actually in the process, we've got some now measures created and all these things that are being validated. What we're trying to do with that work is basically understanding the more proximal mechanisms that connect intimate partner violence and these poor reproductive health outcomes, specifically unintended pregnancy, in that case, because it's not, obviously, the violence itself is often not directly tied to an unintended pregnancy. It certainly can be in the form of sexual violence, and that's a big piece of this. But what that intimate partner violence is often a marker, again, for all of these other types of coercive and controlling behaviors, including ones around reproductive health. One thing I didn't put up there is abusive male partners are also much more likely to try to control a woman's decision once she's gotten pregnant in terms of whether she's going to seek an abortion or not, in both directions, stopping her from getting an abortion she wants, forcing her to get an abortion that she doesn't want. So it's all part of that spectrum of control. But Anita wants to.
That's a big question. When we had discussion about making this panel, there was sort of a decision around focusing around the issue of intimate partner violence. But we've been doing a lot of this work around sexual violence as well, and there's a couple of issues that really impede our ability to understand this concern in India. Number one, a lot of the data that you've seen us present is from DHS. And that gives great population data on violence. The problem is DHS doesn't have a sexual violence item outside of sexual violence in the intimate relationship. So that's one reason we just don't have the kind of information we'd like. Number two, this is just some of the studies that we have. We've been collecting data from various populations in various ways for, for me since 2005, I think for you since like 2003, and we've always put in sexual violence questions. Well, very interesting phenomenon happens when I ask about sexual violence outside of the intimate relationship. We did a study, so we have a study that we had that's not presented here with sex workers. We have done the studies that we have here with the wives who report intimate partner violence, with women in the rural communities. The rates of sexual violence reporting are incredibly low, even among sex workers. So, and we've done it in quantitative ways, we've done it in qualitative ways. The disclosure is just far lower than we would have expected. I don't actually fully understand why. I do know that when we look at the data if I asked if they were forced to have sex, that's why that wasn't in there. It's called sexual coercion, and we can get it if it was like forced or pressured, or if we provide some softened language, then we can pick it up. And I think that there's probably people who do this better in India who are doing this work right now, but we've had a really hard time just having measures that pick it up, because it doesn't make sense. Now, put that aside for a moment and let's just talk about where the data does exist. We've been looking at the crime data on sexual violence. That is consistently going up. Probably about 6 months ago, people asked me to do a sort of a piece around that, and I said, I just don't know, because it could be reporting. I am watching what's happening, and we've been talking as experts, especially since December. We don't think it's reporting. What we think, we don't have great data to prove it, what we think is happening is, with improved mobility, there has been heightened vulnerability. And so we actually think it is picking up a trajectory of increased violence in India. And I'm only speaking for India, because we've just been really focused on it.
Just to very quickly, I mean, when you have contexts where marital rape is legal, where even in the media, even with all of this going on, if you read the media in many parts of South Asia, it's incredibly victim blaming, even in these cases where it is so obvious that she obviously had no part, and there's no way she could have stopped that. So that context is important to pay attention to.
I have to say this because it made me so angry when I saw it. Times of India, those of you who may not know Indian papers, it's considered a very, very good paper. I read it regularly. There was a gang rape that was reported very shortly after the rape in Delhi, and it started, her only mistake was going out to get samosas. It was about a rural girl. Her mistake? And I was livid. I guess enough people were livid, it got pulled very quickly. It is an English-speaking paper. But, yes, I think that it really is a testament to Dr. Silverman's point that these things are changing, but they are, how we state things and how we present things, it's maybe not changing as fast as we'd like.
We have a question in the front of the room.
Hi, I'm Willow Pequanot, NIH. I'm interested in probing more about the sexual coercion as well. The 83% seemed extremely high, and I wondered if there was any way to tease out the issue of culture where men don't really consider themselves men until they've had a child, until they've fathered a child, and whether you could sort out that issue apart from the background that contributes to their being abusive and wanting to perpetuate themselves as well.
Those studies have been done, I'm sorry, pretty much universally in the U.S. at this point, and I think the 83%, it was an 83% greater likelihood if they were also perpetrators of intimate partner violence. As compared to men, right, who are not abusive intimate partner violence. So what you're seeing is it's an unsurprising, strong relationship, because what is always behind intimate partner violence in the 20, 30 years I've been working in it is an entitlement that I have a right to control this woman or this girl in all of these areas, and one of them certainly is reproduction. So it's not surprising at all to me. I mean, it's this more proximal and mechanistic piece, apart from just the physical violence.
So you don't have statistics on non-abusers and whether they coerce women?
Oh, no, we do. Oh, yeah. These are from, large panel studies of men. So compared to non-abusive men, in these same studies, the women who were physically abusive were 83% more likely to also report the pregnancy coercion.
Can we just get a mic up here, please?
The sexual violence or physical violence. When we did a study here of African American couples, we found that we did a very in-depth sexual abuse evaluation. Gail Wyatt was one of the investigators. And you really had to describe what you meant by physical abuse and sexual abuse, or they didn't identify it that way. They would, there was a lot of self-blame. Oh, I irritated him, I didn't have dinner ready, or things like that. They just didn't think of it as abuse.
We should talk to Gail about that.
So one of the best things about being a moderator is I can choose when I get to ask my questions. So, Carrie, I actually have one for you. You had brought up that marriage between cousins is associated with less risk of violence against women. And I'm wondering if you could expand on that a little bit more. I had certainly thought about, or I'd assumed that a woman in a marriage such as that would perhaps have less familial support if she wanted to leave, but I hadn't thought about it from that angle. So if you could talk through that, that'd be great.
So that is actually, that's two sides of the same coin. If you're marrying into your family and it's an abusive family, it's really bad news, because you're not going to get support, because it's all the broader family. But in general, it's perceived that when you are marrying into the family, you're known to everyone. There's a general expectation that you're going to be treated well. I mean, this is your family, the individuals whose job it is to protect you. And so you could, in that way, also have a lot more protection. You've also possibly grown up around these individuals, and the expectation is that there's going to be more compatibility. And it's going to be easier, for example, for you if you tell your father and he's going to go tell his brother, this is really not working out, and to intervene early. And that's really where we saw some of the most effective family interventions, was really earlier on in the process when things were really not going well with one party. And so if you're married into a more extended family, you're of usually the same social class. You don't have huge power and differentials between the families, and things may be easier to deal with early on.
I feel like I may have been neglecting this side of the room, so did I see a question up in the front here, or otherwise? Okay, been neglecting the back as well, so.
Hi, Kelly Pemberton, George Washington University. I want to go back to the presentation by Dr. Raj and an earlier comment that was made, actually the comment that you made in your presentation, first of all, about the CHARM program and working with local village providers as being a component of that program. I was surprised to hear you say that those were mostly male, but my question is this. What I didn't hear and what I'd like you to address is working with traditional medicine providers. Particularly in the case of countries like India and China, I think at least from the research I've done and from what I can gather, the governments have done, in both cases, have done a fairly good job of integrating traditional medicine practitioners into the national healthcare system. Not to say that there aren't still problems, there are. But I wonder when I hear working with local providers as a component of a program, whether that also includes these types of practitioners and what sort of obstacles there might be. And I wonder if you can address it both in terms of working with such providers to improve health outcomes for women and girls, but also possibly working with them to identify or to pinpoint problems of violence within particular communities, since they are often a very good barometer of what's going on individually in families.
So I'll do my best. It's a big question and very complex. So I'll try, and then I'm happy to sort of revisit afterwards and also make sure I can get additional answers from our colleagues in India who were really having the opportunity to work directly with them much more than I would get to from California. So the village health providers actually are mostly what people call Ayush, which is the traditional, right? And yeah, there's the National Rural Health Mission has as part of its framework this goal of really integrating the public health system and Ayush providers. And so what we did was we wanted to take advantage of that existing partnership. Just much the way Dr. Silverman was saying, we try to build on what's already there. A few difficulties that were encountered. So the first was when we went and we did this, bringing in the family planning component, people were very open. It's considered very medical. It is consistent with sort of larger messages of an educated family is a two-family, those kind of things that people are kind of grabbing onto. So that was really easy. The gender equity piece, not as easy. And so what we did a lot of trainings, and there were times where individuals were not selected to continue. Sometimes it was a demonstrated commitment didn't seem to be there. People were just sort of given different reasons. We didn't say, we don't think you're getting the gender equity component. But we did look at that and we would do assessments and find out where they sort of were on these issues. We would do the training, and then we would do additional assessments. And if we didn't find people sort of moving through the training process to get the information, we didn't tend to retain them. But the biggest issue we had, so once we got our trained staff, they're fantastic. Oh my God, they're so fantastic. But I think the thing that we were ill prepared for is when you work in the rural areas, historically, when we wrote the grant, always when you write the grant, everything makes total sense. Then you get on the ground and you're like, oh crap, right? I mean, that's always what happens. So when we wrote the grant, it was made very clear to us that the village providers are within the villages, right? So the public health centers and even the sub-centers now are closer to the roads, because how are you going to get things to places, right? And how are you going to get your physicians there? Also, when the physicians come to do their rural rotation, a lot of times we were working with the Naira Medical Hospital. They would have their residents placed there. They were involved in the project. The residents did do some of the programming as well. And the residents, because you had to stay overnight, were more likely, in fact, everybody's been male so far that's been a resident. So for that reason as well. So that's why I said it's mostly male. It's been all male to date. I'm hoping it stays that way, but everybody's like, you need to be prepared, it may not. So we thought the village providers were in the villages, and then this would facilitate more local provision. What we found out was village providers had started relocating to the roads because people would go to that area for medical care. And many thought that if they didn't have faith in the public health system, they'll go to the village provider, the private practitioner. Even if the private practitioner was people didn't distinguish the types of physicians. So the location was really bad. So then we had to figure out ways to get the provider to the village and to get the men to the provider. That did change the model. Our goal was that 3-session model, and we realized we had to get it down to 1 session because the likelihood of men being able to get there, and how much the village provider, how many men they would be able to see when they would go there, was going to be really hard. That was going to be really hard. So I think that was our biggest barrier. That was really our biggest barrier with implementation. Or I guess is. We're still in the field. So thank you for asking.
So another question in the back.
Hi, my name is Millie. I'm actually a maternal and child health doctoral candidate at the University of Maryland, College Park. And I'm in the process of actually writing my dissertation proposal. I'm using the DHS data, and I'm looking at women who've faced violence during pregnancy, but I'm interested in looking at how it's associated with the maternal health care utilization, so antenatal care and institutional delivery. I'll actually take the liberty of asking you two questions. One, as a researcher, what I'm right now being challenged by is how correlated my independent variables are in terms of, because DHS collects information on sexual violence separately, emotional, and then physical. So if you could address that a little bit. And I also happen to be from India, and I've worked extensively in the field. So I know that mothers-in-law in the family have a really, really strong role to play as far as health-making decisions of the daughters-in-law are concerned, immunization especially. I've worked with UNICEF on polio for 3 years in Uttar Pradesh, so I know that they have like a big, big say in whether the child will be vaccinated or not. So do you have any program in the field in India right now which is addressing this whole intimate partner violence thing with your beneficiaries as mothers-in-law and addressing them, and with some kind of education for them?
So I guess this is to me because it's India, but I'm going to hand off. I think I'm going to have you guys I'm going to hand off to you on the intimate partner violence questions, because I think you've done some really beautiful work on really thinking statistically how to disaggregate the different forms of partner violence, to have it as a combined variable, and then think through that you've done the physical and or sexual, those pieces. So I'm going to hand that off. For there's somebody who's doing a project right now, Sunitha Krishnan, who's doing something called Bill Mill. Very, 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 very nice study funded by National Institutes of Health, where it's a mother-in-law, daughter-in-law intervention around intimate partner violence, and it's in the clinics. Is it around maternal health? So there's that one, and then there's Your Chance program integrates in-laws. We were going to integrate in-laws into Charm, and the men didn't want them there, so we booted that part out. But go ahead. Why don't you talk about Chance as well, and how
Well,
in-laws?
I mean, yeah, obviously that model integrates in-laws. I mean, everything that you're saying is certainly stuff that's been borne out in the data, and certainly were our hypotheses, especially if they don't necessarily have to be, co-residing even in a home, but they're often maybe half a mile away, so they still have a huge influence. And actually, Dr. Raj has done a number of studies about in-laws on this. The question around looking at those data, it really depends on what are your outcomes. Physical and sexual are more easily defined, and there's less controversy over than emotional, even though we know in practice emotional is very important. It's a less reliably defined construct. We often do work where we're looking at physical and sexual separately, at least at first, because in many of our studies, physical is important and not sexual, or sexual is important and not physical. That was true, let's say, for actually HIV, that it was, sexual violence was a huge predictor, and actually when you accounted for that, physical violence was not. Not that it wasn't occurring, but it was really not surprising, the sexual violence that was driving that.
Oh, I thought I saw one question over here earlier.
Alessandra Guedes, Pan American Health Organization, World Health Organization. I actually don't have a question, but I want to offer two resources that may be useful. One is PAHO and the CDC recently did a comparative analysis of DHS and NRHS data in Latin America and the Caribbean for 12 countries. And we look a lot at those issues that are being mentioned in terms of certainly reproductive health outcomes, but also violence against children and violence against women and those correlations. So it's available online. You can look it up. And the other resource that may be useful to this crowd is that WHO is about to release policy and clinical guidelines for the health sector response to survivors of IPV and sexual violence. And those are going to be coming out in May. And as you know, they're based in systematic reviews and meetings of experts and so forth. And so I think that would be something to look out for because it would be addressing many of these issues that we are talking about today. Thank you.
And I apologize for not integrating that into the review that I put up there.
I think we have, Narika, you're passing one right there to your, oh, sorry, I didn't see that. Go ahead.
Hi, my name is Rochelle O'Hagan from Women for Women International, and I have a question about the data that showed the incidence of IPV and if this was disaggregated by age at all. If we see that, younger husbands are more likely to commit IPV, or if younger wives are more likely to be victims.
Maybe we could, I saw two more, grab those two and then give you all a chance to answer one
That
shot.
one's easy, yes.
Okay.
Yes, younger is more vulnerable to violence, more likely to perpetrate.
16 to 25, I think is the.
Hi, I'm Katie Meyer. I'm from John Snow Inc. And I recently actually read a report from WHO and PATH that was done in Africa, and it focused primarily on gender-based violence and IPV, but it also stressed that women are also likely to abuse their children. And so I know it's already a huge endeavor to look at the factors affecting violence, but I was wondering if you all had considered adding a component to the mothers to show that that cycle of violence can start with them as well and how they treat their children.
I've done a bunch of work on this, and it is a very important point. Not surprisingly, when you have been chronically abused for some period of time, especially people are traumatized. And the ability to parent appropriately when you've suffered some kind of chronic trauma, especially that is still it's ongoing, you have not had the opportunity to recover. And we do see that post-separation, when women have opportunities to recover from trauma, women and children, then parenting absolutely does improve. But it is a huge challenge in a situation where there isn't going to be that separation, and that's where local services are absolutely critical.
Can I ask a question too at some point?
Oh, go ahead.
This is actually for Dr. Clark, because I actually know she's done this wonderful work, and I feel like it's something we want to really make sure to bring up. How is conflict how is conflict intersecting with these issues, and what is the meaning of that for the relation between IPV and maternal health?
Civil conflict.
So I wondered whether to put it in the presentation or not. Dr. Raj had encouraged me to, but 15 minutes, trying to stay focused. I think the broader context and going back to the ecological model is crucial when we start to think about the environments in which women live. One of the papers that she's referencing is one that I collaborated on with some colleagues in Jerusalem, looking at women's experience of intimate partner violence in the West Bank and Gaza Strip in relation to their reports of exposure to political violence. And we found a connection between the two, controlling to the best of our ability for other confounders. This research is a little bit complicated, in part because there are a number of factors that we can't control for when you start to look at intimate partner violence and the type of studies that you get good intimate partner violence data, and then more in terms of the data that's available on exposure to political violence. These are oftentimes different fields, and we're unable to really control to the extent that we can. But what we can look at, and then in the West Bank and Gaza and in other places where it has been looked at, is that there are associations, and it's not totally unexpected. Lots of potential mechanisms, many of which we cannot directly test, but we know, especially in West Bank and Gaza, the pressure cooker that individuals live under. Also, when you start to lose your traditional sort of handles on, for example, aspects of masculinity and manhood and honor, women are the ones that get clamped down on, and this is often the case not just in conflict but in other areas of stress. So there's lots of potential ways, including PTSD, and we find with the veterans, once you really start to look at, for individuals who are traumatized in war, they have an increased likelihood of perpetrating violence when they come home against their wives. But looking more at their own mental health and what you do when the findings that you have after you control for PTSD and other sort of comorbid conditions, you see that the relationships are reduced considerably. So really, when we look at these issues in the context, the research really at those outer levels of the ecological model is still sparse. There's a table I didn't show you to spare you, but really it's stark just looking at it in a table that the factors that we look at on women's experience of violence are predominantly characteristics of her relationship, or the perpetrator, a little bit about their relationship, a little bit about the family and the wider community, and very little about the broader context in which these individuals live. And I think that that's really an area for research. These are the complex things to try to measure, especially quantitatively, but they are absolutely worth trying to measure because those are really the underlying factors, especially patriarchy and misogyny and all these other aspects, including, poverty and the pervasiveness and what that does to an individual, to a family, to a relationship, and including political violence. Really looking at those connections, I think, are critical gaps in the literature.
So you are running low on time, but I feel like I did make a commitment to this question on my left. So we'll grab that, and then I just encourage everybody, if you have remaining questions, I think our speakers probably won't mind staying a couple extra minutes for that. Thank you.
Thanks for this opportunity. Hi, everyone, and thank you so much for your presentations today. My name is Michelle Ahmed. I actually have neither a professional nor academic affiliation with the field of domestic violence. However, it's an issue that I fervently follow. I have volunteered with offenders and survivors alike, women and children, and also in my current position as a career services professional. That's how unrelated it is. But I'm a career services professional at the Washington Center for Internships and Academic Seminars. And part of my work there, sort of on a volunteer basis, is to lead a group of about 20 to 40 students. This is our second semester doing it, who educate, advocate for, and research the issue of domestic violence. And these are students both domestic and international. So that's been a great experience. My question stems from Dr. Silverman's point. We're revisiting it, but his point about malnutrition and stunting, seeing that really only for girls. And I'm curious, so it sounds like that's only for, so if girls once they've been born. But I'm curious if the three of you have seen in your research or in other studies instances where if you have a couple experiencing IPV and the woman gets pregnant, and again, I don't know what the resources are in rural areas, but they discover that she's going to have a girl. Do you see instances where perhaps the violence is increased and then that leads to, sort of negative health outcomes for the daughter once the daughter is born?
You're referring, I think, to, sex selective, where people often talk about sex selective abortion in India. So at resource, which is actually illegal to perform, purposes of sex selection, illegal to perform an ultrasound. Obviously that gets to this unpreference, the thing that was Dr. Raj was mentioning, that absolutely is related to violence. So you certainly have a greater risk of violence being there in the first place if this is what's going on. Studies have been, mixed around this sort of gendered effect. Very few studies have looked at it, and you have to, again, have a pretty well-powered study to look at it. I know in some of the recent work that Dr. Raj has done on the DHS, have also looked at some of this a gendered effect of basically what's happening once you're born a girl or you're born a boy in terms of nutrition, right?
So, I mean, I would reference the two studies that you brought up before, your study on the infant mortality differential, that IPV is related to girl infant mortality, but on boy infant mortality in India, we're seeing similar indications around malnutrition. With regard to sex-selected abortion, I feel pretty strongly that while I am concerned about impeded access to abortion services under the guise of protecting girls, and there is absolutely an issue with sex-selected abortion in India and South Asia. I am not sure that the concern is best served with these criminal justice approaches. I think that supporting girls and families to have greater value for the girls that are born is a better long-term solution. And in the interim, I have some concerns about the co-opting of the sex selection abortion movement by individuals who are working to restrict access to reproductive health care services.
Okay, so I usually conclude by mentioning to everybody that we should continue to have this conversation, but I feel like we aren't done with it, so definitely let's continue to have it. I'd encourage you to visit our website at wilsoncenter.org or our blog at newsecuritybeat.org. You can follow us on Twitter or Facebook. I also want to point out, since we are talking about abuse, a session we'll be having on May 2nd, slightly different context when we talk about abuse. The title of the event, and there's flyers outside, is Addressing Disrespect and Abuse During Childbirth. So we'll be focusing on providers at that time. So now I'd like to thank you all for making this discussion great and ask you to join me in thanking our speakers. Thank you. Wow. My three heroes.
Oh, I hadn't showed you. Yeah. Oh, hi.
UC Berkeley grad here, so
Oh,
so